Ohio Hospital Association's statewide sepsis initiative. I am James Giuliano, and I serve as Vice President of Quality Programs at the Ohio Hospital Association. Today's program will consider the role of antimicrobial stewardship in sepsis care. And joining us on our call today are members of the OHA HIN, the OHA statewide sepsis initiative, the post-acute care community, the Ohio Department of Health, and the Health Services Advisory Group. If we could please advance to the next slide, please. Before we begin today's call, I would like to take a minute to call your attention to two separate sepsis-related educational programs. Next slide, please. The first one is a regional outreach program that we talked about at our last monthly call, and that is a program known as Sepsis and Medical Emergency. This is interactive programming presented by Dr. James O'Brien, the chair of the Sepsis Alliance Board of Directors. This program has been approved for 2.0 AMA Category 1 credits. Next slide, please. And as you know, this program has been offered regionally in Southeast, Northeast, and Northwest Ohio. The last offering will be on Monday, April 24th in Central Ohio at the Mount Carmel East Siegel Center from 7:30 a.m. to 9:30 a.m. Next slide, please. There are two options for attendance at this program. You can opt to attend by webcast, as you're doing today, by registering at the link provided, or you can opt to attend in person, also registering at the link provided. Registration is required. There is no fee for the program, but we do need your registration. So please, I would encourage you to attend this program if you have not attended already. At this program, Dr. O'Brien really covers a lot of territory and really talks about the unintended consequences as well of the elements of the 3R bundle. Next slide, please. The second program we'd like to call your attention to is just a save the date for the OHA's 10th Annual Quality Summit, which this year will be held on June 14th at the Hilton at Easton in Columbus, Ohio. Our topics for the three panels include antimicrobial stewardship, iatrogenic delirium, and sepsis. There will be poster presentations as well, and a call for submissions has been sent out. You are encouraged to submit those. Thank you. Next slide. There is no cost to attend this program. Lunch will be provided, but registration is required. And so again, we would ask you to take a moment and consider registering. Our registration is open now at ohiohospitals.org/annual-meeting. Next slide, please. We always begin our calls by revisiting the goal of this statewide initiative, that being to achieve OHA's board-directed goal of a 30% reduction in sepsis mortality statewide by the fourth quarter of 2018. Before we begin today's session, we would like to address a few important details. The first one being that a vital component of this statewide initiative involves the collection of data. Let me take a moment to remind our participating hospitals to please submit your monthly numerator and denominator data regarding compliance to the elements of the 3-hour bundle. Please also know that you will be given an opportunity to type in questions through the chat box feature throughout this presentation. Questions will be addressed at the end of the presentation. Also, just so that you know, this presentation is being recorded and will be posted on our sepsis webpage, which can be visited at ohiohospitals.org/sepsis and by clicking on the education link. There you will find all of the previously recorded sessions that do not contain data. This particular program has also been approved for 1.0 contact hours of continuing nursing education. If you wish to claim this activity, please be sure to complete the sign-in sheet and the evaluation that has been emailed to you, and please fax those back to OHA using the fax number listed at the top of the forms. It is imperative that you provide the correct email or postal mailing address to which you wish to receive your certificate of attendance. Our topic for today's call is antimicrobial stewardship in sepsis care. Our focus upon early recognition of sepsis symptoms had helped us to intervene appropriately by drawing blood cultures prior to the initiation of broad-spectrum antibiotics. Now, taking this a step further, and joining us today are two presenters from the Kennedy Health System in Stratford, New Jersey, who will share their expertise, experiences, and valuable tools for integrating antimicrobial stewardship into the care of the patient with sepsis. The slides and the tools that they will refer to will be available on the OHA website. Dr. Cindy Ho is the Infection Control Officer at Kennedy Health and an infectious diseases specialist with Kennedy Health Alliance. Dr. Ho also serves as the Physician Chair of the Infection Control Committee, Antimicrobial Stewardship Committee, Sepsis on the Floors Task Force, and C. diff Task Force at Kennedy University Hospital. She was named Physician Champion for the New Jersey Hospital Association's Antimicrobial Stewardship Collaborative, a 3-year initiative. Dr. Ho earned a Doctor of Osteopathic Medicine degree from the University of New England College of Osteopathic Medicine, a Master's degree in Business Administration, and a Master's of Arts degree in Medical Science from Boston University, and a Bachelor of Science degree from Yale University. She completed a fellowship in infectious disease at the University of Medicine and Dentistry of New Jersey. She is a fellow in the American College of Osteopathic Internists, and she also serves as an active member of the advisory board for the Lupus Asian Network, Lantern, of the Hospital for Special Surgery in New York. Also joining us today is Mary Ann Kramer, Chief Nursing Officer of the Kennedy Health System in New Jersey. Mary Ann possesses a solid clinical foundation as a board-certified critical care nurse and as a nursing leader and healthcare administrator. She has led numerous initiatives to improve the care of the patient with sepsis, including, but not limited to, lactic acid and blood culture nurse-driven protocol implementation. In addition, she has lectured extensively on the impact of leadership upon sepsis mortality reduction. Mary Ann holds a master's degree in public administration from Rutgers, the State University of New Jersey at Camden, a master's degree in education from Temple University, and a Bachelor of Science degree in nursing from Widener University. Both Dr. Ho and Mary Ann's work on culture, practice, and sustainability have been noted through their presentations and their leadership of the New Jersey Antimicrobial Stewardship Collaborative, as well as their March 22nd, 2017 APIC presentation entitled The Role of the Infection Preventionist in Sepsis Care. In September of 2016, they were recognized nationally with the Sepsis Hero Award by the Sepsis Alliance. It is now my pleasure to welcome back to Ohio Dr. Ho and Mary Ann Kramer. So I'll turn the floor over to you.
Good morning. Thank you so much to Jim and the Ohio Hospital Association for giving us the opportunity to talk today. And in this presentation, basically, the first number of slides I will perform and lecture to you about, and then I'll pass it over to Mary Ann, and then I'll wrap up at the end. So first off, next slide. In case you're not familiar with Kennedy Health, we're located in South Jersey. We're a division of 3 hospitals, and there are, of course, other outpatient centers. In 2016, we had over $600 million in revenue. There are more than 1,000 physicians. And as they say over here, if location-wise we're in South Jersey, across the bridge, and there's Philadelphia, to give you some context. Next slide. So today we'd like to talk to you about sepsis and antimicrobial stewardship. Specifically, it's always a little risque, but we believe that if you can fine-tune infection prevention, this can prevent cases of sepsis. And then lastly, we'll bring in the role of cultures, specifically blood cultures, and how that can help to combat sepsis. Next slide. The model that we see for stewardship is something that's had different layers, really. You probably notice in our bios how there's kind of this or that committee, And the truth is everything kind of builds on each other. So we have separate committees, for example, for infection control, one oversight committee for the 3 hospitals, one oversight separate committee for antimicrobial stewardship. And then for sepsis, we're kind of hardcore. We actually have 2 separate sepsis committees. And yet there are some similar players and yet different players in all 3, and all of them overlap to help to improve the care of our patients. Next slide. Of course, we're going to start out with defining sepsis and antimicrobial stewardship. Next slide. Just one of the important things to do when you're educating about sepsis is to ensure that your staff understands it, but more and more, when you have the opportunity to, it's important to educate the patient, and if they're sort of still sickly, then it's important to educate family members, because often they may be the first ones to detect what sepsis is. And having your collaborative, you obviously know what sepsis is, but this is a patient information sheet, or at least part of it, that just this morning, actually, I printed out for a family member, and I explained the gist of sepsis so that they could be an advocate for their family. Next slide. And it's really a single page, but for the purpose of the slides, it's separated into general language of how sepsis is treated, how sepsis can be prevented, and how to get more information. Next slide. Along the way, when we've uncovered knowledge gaps for sepsis, one of the potential gaps we realized was really just patients who initially present to the ER. You know, it's one thing if you go to triage and you say, kind of vaguely, I don't feel well, and potentially hard to tease out what's going on. So one of these signs is actually around in triage, or where people come in when they first come into the ER, because they may not be aware that some of these symptoms are potentially sepsis related. So it says, speak up, let's beat sepsis together. Tell your nurse if you or a loved one experience these symptoms. Fever or chills, faster breathing, faster heart rate, or just confused or not acting right. Next slide. This is a graphic from CHEST, and it's kind of old in 2003, but I'll kind of reiterate it a little bit later on and meld together antibiotics. And when I look at this slide, I'm reminded by what one of my colleagues said, which is he told me, Cindy, sometimes people have sepsis and they don't make it. And it's true, obviously, as this slide may show, that if you have sepsis, you have higher survival than severe sepsis, then worse yet, septic shock. But the way that I've seen it is his statement was almost like, well, let's see what we can do about it. What are the things that we can control? Next slide. This is a very involved slide, and we're getting very good with sepsis and so on, and we realized as we participated with the New Jersey Hospital Association's Sepsis Collaborative that there are times that we didn't really synthesize the pieces or all the components of end organ dysfunction. And also that particular collaborative was mainly focused on severe sepsis and septic shock. So the way this is read, you can imagine that these slides are in different places or posters. And the yellow is sepsis is 2 of the following plus a source infection. It has the SIRS criteria, the bandemia. It says if you have identified sepsis, draw stat lactate because we have a nurse-initiated lactic acid policy. And we have adopted the threshold of greater than 2 for the physician to be called. Severe sepsis, you basically have the left-hand column plus end organ dysfunction, lactate greater than 2, altered mental status, acute kidney injury, elevated troponin, ARDS, new or worsened ALT, AST, the urine output is less than 0.5 cc's per kilogram per hour, or new or worsened platelet count less than 100. So you would call an RRT, and then there's septic shock, where you might still be the middle column plus you're hypotensive despite a 30 cc per kilogram bolus. And so it becomes very easy to see where somebody might fit, and you can also see how septic shock really is an entity that before it is septic shock, it is severe sepsis, and before it is that, it is sepsis. And so what we're trying to do all the time is to identify items when it's just sepsis before it progresses into something else like severe sepsis or septic shock, where your mortality is much higher. Next slide. And essentially this particular slide is similar, but just kind of a simple infographic of green is sepsis, yellow is sepsis and organ dysfunction, and then septic shock, in similar terminology, but kind of oversimplified. Next slide. And one of the things that we can control or try to control, and we've looked back and we've been asked this question, what do you think really, really helped? And it was about attention and fine-tuning the 3-hour bundle and really having those discussions when there are fallouts. As you're well aware, the 3-hour bundle consists of the lactic acid plus a blood culture before the antibiotic, a broad spectrum antibiotic. We would say that it should be tailored to the specific patient and the possible bacteria that are involved. And then you may need fluids, of course, with hypotension or a lactic acid greater than or equal 4. Next slide. I just want to briefly touch on the Q-SOFA score. You probably are familiar with this. This is a quick sepsis organ failure assessment score. It's kind of been in the literature. It's based on low blood pressure, high respirations, and a change in mental status, or specifically a Glasgow Coma scale of less than 15. There's a particular website there, which is aptly named qsofa.org. And the score risk is 0 to 3. So if you're like a 2 or 3, you have a higher risk for mortality. And the Q-SOFA is something that you use only when you suspect infections. It's kind of in that capacity. Next slide. The specific Q-SOFA calculator that I do like to use when I have the opportunity to use it is available at that particular website. It's just really easy instead of kind of calculating the numbers. And what's nice is you punch in those numbers as usually the highest respirations or lowest systolic blood pressure. So if your patient is in the emergency department for, say, 2 hours or whatever the time is, you take the highest respirations, lowest systolic blood pressure, and you click submit. And it would give you an interpretation or score in the risk for mortality. Having said this, I would tell you that personally, I don't use this all the time. I tend to use it more for people who are septic shock. Next slide. Just a little bit about, you know, in our current recognition of sepsis in our hospital system, we kind of go by sepsis, severe sepsis, and septic shock. As you may be aware that the definitions are changing in the Journal American Medical Association in 2016, they suddenly decided to throw out their sepsis 3. So essentially the definition of sepsis has been changed 3 times, previously in 1991 and 2001. And essentially the main difference is that they consider that all sepsis really has organ dysfunction. So it sort of eliminates that severe sepsis. And yet they also integrate that your SOFA score has to be greater than or equal to 2. Essentially, at baseline, everybody's SOFA score is 0. Next slide. So particularly, they say septic shock is a subset of sepsis in which underlying circulatory and cellular metabolic abnormalities are profound enough to substantially increase mortality. In other words, you're on vasopressors, your lactic acid is greater than 2, even with adequate IV fluid resuscitation. Next slide. And changing gears a little bit to antibiotic stewardship, there's a phrase antimicrobial stewardship, and that would encompass if you had antibiotics, antivirals, antifungals. For the purposes of this particular lecture, we're really going to just talk about antibiotics, and therefore it would be antibiotic stewardship. And according to the Infectious Disease Society of America, or IDSA, basically these are interventions where you want to improve and measure the appropriate use of antimicrobials. And this is involving the selection of the optimal antimicrobial drug regimen, the dose, duration of therapy, and route of administration. Next slide. You are looking at, again, emphasis on dose, duration, and route for a specific indication. Next slide. Some of the goals you're trying to achieve are, obviously you want your patient to do better, but at the same time, you want to minimize toxicity. What the heck does that mean? So basically, when you try to treat an infection, you want them to be an optimal antibiotic, but even though you're thinking about the here and now for their particular infection and the reason for their sepsis etiology, you're actually also thinking about potential downstream impacts. So what can you do in your selection of antibiotics to minimize the chances that they'll get a second infection? How can you reduce their costs and limit the selection for antimicrobial resistant strains? And your selection of antibiotics is very important because what you choose can actually be a risk factor for C. diff. Next slide. This sign is called Antimicrobial Stewardship, admission through discharge. I realize that some people may not necessarily work in a hospital setting, but you could kind of slap on there, you know, post-acute care setting, or long-term care, different avenues, and even to some extent, even in the outpatient office setting. It would be slightly different, of course. It would be kind of, at presentation, then during the course, and then when they are close to completing the treatment for their infection, for example. But the selection of antibiotics is very important, and based on so many different factors. You have to deduce and work up what is the source of infection. If you are unfortunate enough to be in the hospital, it is kind of fortunate for the provider because you have the ability to get stat labs and cultures and studies that you can get, very quickly, or there may be a historical record. And that's very important because if they had prior resistance, they could have current resistance. Antibiotic allergies are also very important, and it is actually a form of antibiotic stewardship. All antibiotics are not benign. They actually have to be dosed and carefully based on their age, their creatinine, and if they have seizures or an pre-existing long QTC interval. And then ultimately what you select is based on the most likely source and the possible pathogen or pathogens. To borrow from the CDC, as they go along in their hospital course, there is an antibiotic timeout, where currently we have an assessment at the 48-hour juncture to determine if the antibiotic is still needed. And if it's not good, stop it, or you de-escalate, which means you change the antibiotic to an antibiotic which is less broad or more narrow in spectrum. Sometimes when the patient is still hospitalized, you may be able to determine a dose duration and stop date at that moment, and sometimes it's not clear until discharge, where you again have to perform antibiotic reconciliation, much in the same way that you would do discharge medication reconciliation. Next slide. So this is a very similar slide to that one CHEST article, and it drives home the role of antibiotics. So in the green, it says sepsis, severe sepsis, and appropriate treatment. So if you have sepsis or severe sepsis, but you're on the right antibiotics from the get-go, you have the best chance of surviving. You can see that if you have sepsis and severe sepsis, but you're on inappropriate treatment or the wrong antibiotics retrospectively, you have a higher chance of dying. We know that septic shock, you're physiologically disturbed, so you already have, the odds are against you, but at least if you're on the right antibiotics, there is a higher chance of survival than the worst possible one, which is letter D, septic shock and inappropriate treatment. So to me, this slide, even though it's a very old article, it best exemplifies how antibiotics really tie into sepsis. Next slide.
Hello, everyone. It's Mary Ann. Welcome. We're glad to be back and be able to talk to the folks in Ohio. We want to switch gears a little bit and talk about how understanding how infection prevention can help prevent cases of sepsis. Next slide, please. And we understand that there is a relationship of infection prevention to sepsis and antimicrobial stewardship, that we want to reduce the chances of employing broad-spectrum antibiotics for sepsis that will prevent infections from occurring in the first place, and that we want to reduce chances of acquiring multi-drug resistant pathogens, which make treatment of sepsis more challenging and emphasize infection control measures. Next slide. For example, how do we prevent multi-drug resistant CRE? And we know from the very beginning, every infection can be prevented by good hand hygiene, and that contact precautions if infected or colonized with CRE. We want to minimize the use of devices, ventilators, central lines. We want to bring on the antimicrobial stewardship and environmental cleaning. Next slide. And educate patients and families about infection prevention, antibiotic stewardship, and more. And like Dr. Ho mentioned earlier in the beginning about our education sheets on sepsis and the fact that she printed on demand and gave to a patient, we know that the informed patient is more likely to be compliant with therapy and can be that co-pilot in preventing infections and an understanding when antibiotics are needed and when they're not. And the informed family member can also learn how to prevent infections. And we know with all of our C. diff work, and I'm sure with all of you, teaching the family member how to don and doff the proper PPE when going into a C. diff room. Next slide, please. And staff reminders, and Dr. Ho showed you some other signage earlier, and we want to prevent sepsis before it occurs. And we know that we can, and being diligent in some of these practices really will make the difference. And like in the beginning, like in the center of our circle, it's always to wash your hands, every time. And to proactively manage our high-risk patients and to educate patients about infection preventions. We want to prevent C. diff. We want to prevent aspiration pneumonia. We want to prevent peritonitis, prevent surgical site infections, and prevent CLABSIs and CAUTIs. Next slide, please. Patients can acquire device-related infections and can get septic. Any device that is foreign to the body is a risk factor for infections. But the risk for infections can be decreased with attention to infection prevention at insertion, maintenance, and removal when no longer necessary. And we're getting to the bundles. Next slide, please. And we talk about, next slide. Okay, and we talk about the life cycle approach and the life cycle of a central line prevention, preventing infections throughout the life cycle of a central line or PIC. We look at the bundle, before insertion, at line insertion bundle, the maintenance bundle, and the line removal bundle. And I'm sure you're all working this through as we are, and we put a lot of work into each. Whenever there would be a fallout, we went back to that part of the bundle to see which part we possibly missed. Next slide. And again, central line precautions, the 5 precautionary steps: wash your hands, scrub the hub, change your dressing every 7 days if loose or soiled, and that's our policy. Changing the tubing every 4 days, that's a Kennedy policy, and to document daily. And what we're documenting is not just how the catheter looks, but the necessity for the line. Is there still a reason to have that line in to begin with? Next slide. And the focus on hand hygiene, another one of our new signage. We change our signage frequently so it doesn't get old, but the message stays current. Again, hand hygiene at the insertion, the maintenance and removal, and the reinsertion of any of our urinary catheters. Next slide. One of the things we spent time on internally here at Kennedy is really getting the difference between C. diff colonization and C. diff infection. And we do realize that colonization is more common than infections. And we look at if there are no symptoms and a positive C. diff test, it's colonized. But if there an infection is if there's C. diff symptoms and a positive C. diff test. So we really are looking at symptoms and not just the diarrhea. That could be a cause from other things. The next slide. And our C. diff infection, is the diarrhea antibiotic associated, tube feedings, or laxative associated? If yes, then we would check, then we would know that it's not C. diff. If the patient has 2 infections, C. diff and a second infection, can the antibiotic for the infection be changed to one less likely to irritate the C. diff? And if infection needs to be treated and there is no C. diff, can an antibiotic be chosen which is less likely to induce the C. diff to begin with? Next slide. And this is a sign that Dr. Ho had put together, part of our task force. And what's bolded are the antibiotics that are high association with C. diff. And even in the high risk, medium risk, and low risk categories, there are still some high antibiotics for a risk for C. diff. And we have these signs hanging up in the physician areas and the nursing documentation areas, the charting areas, because even though the physicians order the antibiotics, that we want our nurses to understand that the different categories of antibiotics, and if a patient is on Levaquin, for the organism, could something from another category or lower in the list be chosen instead to help minimize the risk of C. diff? Next slide. And some of our additional nursing initiatives that we do, device infection drill downs with key stakeholders. And we've talked about this before of looking at a break-in the bundle. What could have caused the possible infection? So we bring everybody together and we talk about the elements that led up to the device and then where the infection could have come from. We do urinary catheter rounds. We started this when we were at one of our hospitals when patients were being discharged later in the afternoon from the intensive care unit to the intermediate units. We didn't want to make sure that patients weren't in that critical couple of hours post-discharge, that we weren't noticing any signs or symptoms of their illness. And we realized that maybe we need to look at why the devices went out, and we started doing catheter rounds. And now we have since done it, have to do that at all 3 of our hospitals. And our lessons learned, we share them through shift huddles, department newsletters, safety call reports. And that the charge nurse and nursing super in their rounds, that all patients, like I said, discharged from the ICU to the intermediate units to assess transition status. Next slide. And this is a copy or what we do in our infection control drill down case review. And these are some of the points that we put together, and we really follow this template so that we really get the full story of what could have happened and the reason why or a potential reason why for the infection. And we look at the date of the hospital admission, the reason for the case review, the location of where the device was inserted. Catheters often get inserted, central lines and urinary catheters in the ED, and then the infection shows up a few days later. Was it a break at the ED at the insertion or a break in the bundle on the care of the catheter? The time and date the device was inserted, and the date of the positive cultures. And we look at what antibiotics were used. A review the bundle elements, were they met or unmet, a general discussion or clinical course, and lessons learned. Then we look at creative ways to get the information back to the staff, because it's great that the crew in the moment know about it, but if there's lessons learned, we certainly want to get them out to everyone. Next, please. All right, Dr. Ho.
So I'd like to kind of try to tie some of this together because, you know, in the 3-hour bundle, you draw the blood cultures. What happens with the blood cultures? You know, perhaps you are in the ER and you don't have the follow-through. And the cultures are very important, particularly the blood cultures, to help combat sepsis. Next slide. And I'd actually like to talk about the blood culture section in a couple of slides later on, but have Marianne come back to talk about her role in nursing awareness for antimicrobial stewardship.
All right, so the nursing antibiotic rounds and reviewing a culture. One of the things that we discovered as we were rolling out our antibiotic stewardship work with the nursing side is that we really needed to promote awareness of antimicrobial stewardship for nursing system-wide. And we started with nurse rounds, one-to-one nurse rounds with the infection preventionist and myself and the clinical nurse to review why the patient is on antibiotics. And we would discuss the microbiology report and its relation to the ordered antibiotics. And when we found that we didn't understand why a particular antibiotic was chosen or why the patient was still on it, we brought the discussion to the physician, because we realized it's really the nurse and the physician, the microbiology lab person in absentia, but via the microbiology report, to try to come up with an understanding of the antibiotics. Next slide. And some of the preliminary findings of our antibiotic rounds, we found that the nurses were really not all that familiar on how to interpret a microbiology report, and that they really weren't familiar with all classes of antibiotics, and that oftentimes nurses don't see the uniqueness of antibiotics. The antibiotics are not benign drugs, that there's a real reason for them and the purpose and an indicator that we really need to become more mindful of. And as we were making rounds, I would say to the clinical nurses, would you ever give potassium to a patient without checking the potassium level? And of course, hands down, no one would do that. Then I say, why are we hanging an antibiotic when we really don't know what the reason for the antibiotic and the particular drug class of the antibiotic? Next slide. So that after we did all of that, we realized that we probably need to do more education. So we looked at putting an antimicrobial a course together for nursing that synthesized the interpretation of the culture and sensitivity report and to identify actions, indications, and dosing for the antibiotics. Next. And we wanted to match a culture with the antibiotics. So how could we roll this education out and get an idea where we even needed to start? And it's going back to, like I mentioned a few slides back, that we made antibiotic rounds, that we really realized we needed to do some focused education. So we picked one of the ICUs at one of the hospitals, and we did a pre and post knowledge assessment. The nurse manager and the clinical educator and the IP got together and looked at 10 questions or 10 comments and assessed the nurse's knowledge of antibiotics. Then they rolled out a focused computerized based learning, and they did post-knowledge assessment. And we realized we saw an improvement in the understanding and the reading of the microbiology report. Next. So we looked at, tailoring an antibiotic to the culture. We had to get a work to help the patient get on the appropriate antibiotic to fight against sepsis. That the infection preventionist and the clinical nurse, when they rounded and they found a question or they didn't understand, they informed the primary service or infectious disease to review the antibiotic and the microbiology report. And looked at the team. The physician explained why they might have been on it if it wasn't clear, and it created that team approach to the patient on a susceptible antibiotic. And this really is one of the biggest ways that nursing has, they're so important in antibiotic stewardship, that we hang the drug. We need to understand why. And that when Dr. Ho and I talk, we often get nurses to say, what's our role in this, and why are we so valuable to this? And well, this is really why. It's understanding it and then bringing this discussion forward. Next. And then some examples of our antimicrobial stewardship initiatives are the patient education on the portal, or antibiotics, or C. diff, and other education sheets, our mandatory ID consult for any patient who has sepsis, severe sepsis, or septic shock, a patient who is on 2 or more antibiotics, and a patient who has C. diff. Next. And I'm going to turn it back to Dr. Ho, who's going to walk us through what a blood culture, how to read a blood culture slip.
Okay, so let's imagine that there's a 3-hour bundle. You take the blood culture, lactic acid, and then you sort of pass it off, right? So if you're working in the ER, you may not see the fruits of your labor of the hard stick of the blood culture, and what happens afterwards. Well, some institutions may have fancier tests, and we do, but today I'm just going to talk about the old school blood culture. And as I explain it to patients, it's that tube that looks like a little wine bottle when you go on the plane. It turns out that that particular test has a lot of yield if it's abnormal. The annoying thing from the patient perspective is that it does take time to incubate. In approximately 24 hours, sometimes 36 hours, if a blood culture is abnormal, you'll have a kind of a category. A day later, a pathogen, and normally a day after that, the final blood culture sensitivity results. And the thing with bacteria is that they come in different categories, different shapes. There's cocci, which looks like a circle. A rod basically looks like a rod. Next. Many times, if a blood culture is reported, it may say a type of bacteria, such as this is a gram-negative rod or a gram-positive. Next. And this is very important. So what happens in our hospital system is, as a safety mechanism, the microbiology calls the unit that the patient is on, and then they report the gram-negative rod, the gram-positive cocci, and these are what are referred to positive blood cultures. So it turns out that if you look at it differently, like an ICD-10 code, there are actually separate ICD-10 codes for different pathogens. If you had sepsis due to MSSA, that's a higher degree of complexity than if you just had sepsis. And MSSA would be obvious in the blood culture, which actually has a higher level of complexity than if you label this as bacteremia. Next slide. Again, just a mention about timing, and other items are terminology of antibiotics, because in the heat of the moment in the ER, or if you have the misfortune of being septic while already in the hospital, really what you're giving is what's called empiric antibiotics, right? Because these cultures are going to take some time, and people could potentially have infections and the blood culture could be negative. But empiric means you choose the antibiotic based on what you think is the infection of the patient, while you wait for other tests such as cultures, or perhaps you have to CT scan somebody or do a plain film chest x-ray. And of course, you are examining the patient and taking a history to try to deduce what those empiric antibiotics might be. Next slide. There's a lot of thought into a blood culture, because if you do not obtain it appropriately enough, then it could actually be a contaminated blood culture. And that's important because from an infection prevention standpoint and from quality initiatives, you want to get the best possible blood culture so it reflects a true pathogen. Whereas if it's contaminated, then maybe the skin around the area wasn't kind of cleaned as well, or it can become contaminated later on by the microbiologist if it's not properly removed off of the blood culture and kind of plated. Versus blood cultures can be pathogenic, and when they are, essentially they have sepsis from that particular bug. I will say some caveats about blood cultures. At least in our hospital system, every blood culture is incubated for about 5 straight days. And generally speaking, as a general, very, very general rule of thumb, normally if you're going to have a bloodstream infection, you'll usually see something at the 24-hour juncture. Although there have been times where if there's potentially an endovascular infection, then the blood culture can be initially negative at, say, 48 hours and then become positive at 72 hours. And this is why we should just pay attention to all the tests that are run in our patients. Next slide. So let's give an example of blood cultures and gram stains and calling and what we choose and so on. So let's say we have a 70-year-old man, he comes in septic. Let's go on further and say that maybe, there's a cellulitis or something. So you give an empiric cefazolin, which is a first-generation cephalosporin. That's reasonable because it has skin, strep, staph coverage. Later on, that blood culture that was part of the 3-hour bundle, let's say it's 24 hours later, and there happens to be gram-positive cocci. Microbiology calls the nurse calls the physician. What the physician should then do many times is to reassess the patient. Some people could be extremely sick. Review the differential diagnosis of what are the types of gram-positive cocci, because there really are only a few. For example, if I had to oversimplify it, staph, strep, enterococcus, and then coagulase negative staph. And this is why sometimes when people have gram-positive cocci, maybe somebody is given vancomycin. Let's just say empirically in this case, the physician chose cefazolin. Next slide. And meanwhile, what is happening is in the blood culture and in any other culture, it is really some sensitivity results which get worked up by the microbiology lab. And if we had to oversimplify this, if there's an S next to a particular bacteria, it means in the petri dish that would be sensitive, it would work. There are certain exceptions, and in the example which I'll show later, I'll go over this, but for Staph aureus, there would be some exceptions. R is resistant, that's not gonna work. I means maybe, so you might as well avoid that. So next slide. There's usually a number called the minimum inhibitory concentration. This refers to the lowest concentration of the antimicrobial to inhibit the growth of the bacteria after overnight incubation. And basically, for every culture, you may have this number, and it kind of depends on what you're treating. For example, if you're treating an endocarditis and you really wanted to kill that bacteria, it probably behooves you not to choose an MIC that is very high. But if you had something like a urinary tract infection, well, you may be able to treat it with a simple antibiotic because it doesn't take too much antibiotics, regardless of the MIC, to get the antibiotic concentrated in the urine. Now, of course, we mentioned there's exceptions. For MRSA, which is MRSA, let's say the blood culture says vancomycin, there's an S, that means it's sensitive, but the MIC says 1.5 or 2. This is unfortunately just strictly memorization. But what it means is that there is a chance that the vancomycin might not work. And that's just kind of a nuance of blood cultures and specific pathogens, particularly when it refers to the blood culture. Next slide. And, you know, this, animation didn't come through, but essentially I'll kind of walk through this with you. But what this was going to show was different antibiotics, which are listed in the blood culture result, and then the pathogen, which let's say it was Staph aureus. And in this particular example, I walked through a couple of different antibiotics and the reasons why we didn't go with that particular antibiotic. Let's say there was an antibiotic such as doxycycline. Well, doxycycline is in the category of the antibiotics which would inhibit growth. So think about it, right? You have a bloodstream infection. You want something which is bactericidal. That means it kills bacteria. So goodbye to the doxycycline. We're not choosing doxycycline. Let's say that there is also clindamycin, and there happens to be an S. But again, you know, bloodstream infection, do you want something kind of high risk for C. diff, really doesn't work for bloodstream infection? No. So goodbye to clindamycin. Let's say this person ended up having a cough and shortness of breath, and initially the chest X-ray was clean, but it ended up being pneumonia. Let's say that it was sensitive to an antibiotic like daptomycin, which is also known as cubicin. Well, in this case, daptomycin is really very good for MRSA, but again, it depends on the source of your infection. If your source is pneumonia, it turns out that daptomycin is inactivated by surfactant. So you don't want to choose daptomycin even though there's an S. Let's suppose that this was an MRSA and vancomycin was sensitive, but that level was kind of 2. So we said that was kind of a sneaky one, that even though it's an S, that MIC is kind of high, where it might not work. So goodbye to the IV vancomycin. In this particular case example, we ended up on ceftaroline for reasons of high MIC, that the source of the sepsis was MRSA, it was in the bloodstream, it was pneumonia, and the best option based on this particular patient's cause of sepsis was pneumonia, so it ended up being ceftaroline. So that's sort of behind those red bars in a few sentences. Next slide. I know it was a little bit complicated for that particular example, but it I think really ties in that there are various nuances to blood cultures. We just wanted to summarize again what we talked about today: sepsis, antimicrobial stewardship, the role in infection prevention, and the role of cultures. Next slide. On behalf of Kennedy Health System, Marianne and I feel very fortunate today to talk to all of you. Again, thank you to the Ohio Hospital Association, and certainly we'll stick around if there's any questions. And as we always say, we would love to hear any particular comments, particularly constructive feedback, because, you know, we always want to strive to get better. You know, whether it's a bonus or a ding, like, we got to learn. So thanks again for having us.
Well, thank you very much, Dr. Ho, and thank you, Marianne, for your presentation, for your slides, and also for sharing all of your resources with us today. At this time, I would like to invite our participants to submit any questions that you may have through our chat box feature. And as you are considering those questions for the chat box, I would like to remind everyone of our next call, which is on Wednesday, May 17th at 11:30 a.m., where we will continue our focus on the sepsis continuum of care. However, at this time, we will entertain any questions that you may have. We have over 150 active phone lines joining us today, so I would like to invite you to submit questions. One of the first questions that we have is with regard to turnaround time. You mentioned a mandatory infectious disease consult, and the question is, what is the turnaround time for an infectious disease consult within your organization?
Well, that's interesting, because there are days that I might be rounding super late. So it depends on the nature of the consult. Typically in our hospital system, a routine consult has to be addressed within 24 hours. If it's a stat consult, we have influenced people to pick up the phone and call us, and then we have approximately 1 hour to do the consult. We do encourage everyone who is very concerned about the patient that if it's something that needs to be addressed immediately, they really need to pick up the phone and call us so that we can go over what would be the best possible antibiotic, antiviral, antifungal, whatever the case may be. And so the answer to your question is it kind of depends on the nature of the reason for the consult and the urgency, but otherwise a routine consult turnaround is up to 24 hours. Having said that, sometimes I'm here kind of very late, myself and my partners, and we try to get to everything as soon as possible.
Thank you. Our next question, it says, on slide 40, I believe you stated that you did not test for C. diff if signs and symptoms occurred and the patient was on antibiotics. Could you please clarify that?
Okay, so I'm not sure if I have the right slide, but I think you might be referring to the C. diff colonization. Perhaps I will just speak to that, and if it's not correct, then certainly submit your question. But basically, before a C. diff sample is submitted, you have to have a high pretest probability that it's going to be C. diff. As an example, if your patient has been on lactulose because of hepatic encephalopathy and there's no fevers, no abdominal pain, no colitis, no watery diarrhea, that kind of thing, then, you know, there's a high chance that the diarrhea could be just related to the lactulose. And in that case, if your pretest probability is very low, you wouldn't check for C. diff. There are times that people have the misfortune of having C. diff and having a pre-existing systemic infection. In those cases, that one slide with the green, yellow, and red, what we try to do, it's not always possible, is we try to select an antibiotic which is less likely to worsen the existing C. diff while simultaneously treating the existing systemic infection. Here's an example. If I had somebody with a urinary tract infection, they were just here several weeks ago, and it was susceptible to a first-generation cephalosporin, and they have C. diff, well, they need treatment for C. diff, but maybe you wouldn't want to choose an antibiotic like Cipro, which is kind of in the red, much higher risk than an antibiotic such as cefazolin, or even a more narrow antibiotic or less likely to induce C. diff antibiotic on the kind of the green end. So I'm not sure if that answered your question, but there's different permutations of what we do for people who are at risk for C. diff, have had C. diff, and to prevent C. diff in the first place.
Thank you. Our next question, the writer says, we struggle with care that is provided with a questionable time zero, causing some care to fall outside of the appropriate window. How did you clarify time zero? Do you recommend, quote, on arrival to the ED, as we see in much of the literature?
Yes, we struggled with that too in our early work with our sepsis, and we looked to guidance to our New Jersey Hospital Association and the Sepsis Collaborative and all of the literature. What we do here at Kennedy, we call it on triage, so that when the patient enters the ED, the first person, the nurse that goes out and gets that first set of vital signs, we start there as point zero.
Thank you, Marianne. The next question is, what nursing skills were presented to staff to increase their questioning of escalation or de-escalation of antibiotic therapy?
One of the things that we started when we wanted this to be a conversation, and we wanted that the nurses to get comfortable. We have nurses in 3 different hospitals with all different skill sets and background, new nurses to practice, more senior people, senior nurses. We have house staff who are learning antibiotics themselves to senior infectious disease doctors. So we wanted our nurses to feel comfortable just getting enough awareness of, doctor, this is what the culture report says, you know, and this is the antibiotic they're on. I'm not quite understanding why this one was chosen over that one. Doctor, you know, the blood culture came back and it says this, and the antibiotic says that. You know, I'm not quite sure why it was chosen. Can you explain? We really wanted it to be a team approach. We wanted the nurses to have enough wherewithal to ask the question, and recognizing from our rounds that nurses aren't as familiar with reading the blood culture slips or the microbiology report and the different classes of antibiotics. So we didn't want the nurse to feel set up that they have to go and ask a question and feel intimidated from the answer, but enough to say, you know, I'm not sure, you know, I read the micro report this way, how do you read it? So that we can create that team approach for the patient.
I also give an anecdote that I guess what we're encouraging is that there are, of course, different levels of knowledge of cultures and what to do with them, and it's common for microbiology to call the nurse, and what do they do with it? Sometimes it's a matter of who you talk to, you know. So, for example, if you're a teaching hospital, notification of a culture to a covering intern versus notification of the culture to the covering infectious disease attending, who might be more knowledgeable about adjustments in the antibiotics. And so what we encourage is really reaching out to the attending physician many times, although we also do reach out to the house staff, and so it becomes a conversation.
Thank you very much. We appreciate that. Those are all the questions that I see. Dorothy, from your standpoint, any further questions that have come in?
Yes, one just came in.
Okay.
Yes. Can you further explain the role of pharmacy or the pharmacist in your antibiotic review?
Sure. It's multi-layered and multifaceted. We have an antimicrobial stewardship committee, and we have a lead pharmacist, which is the clinical infectious disease pharmacist, who assists in rounds, and he also has developed rapport with different clinicians, so he has oversight in different items. For example, vancomycin pharmacokinetics, so you have the patient on the proper dose of vancomycin adjusted to height and weight and creatinine clearance, for example. There are also clinical pharmacists that also assist with antibiotic stewardship in the intensive care units, and when there's an opportunity to, on the high-risk antibiotics that are risk factors for C. diff, they will directly reach out to the primary service attending physician, particularly if infectious disease is not involved. And if infectious disease is involved, what if the pharmacist sees the culture before we do? Well, they pick up the phone and they contact us, and we have a conversation about if adjustments are needed. So pharmacy plays at our hospital extremely valuable role, and it's something that's not occurred overnight. Certainly, you have to engage and have people become a team. And that's how they have really helped us with all of our initiatives. So they are invaluable. We didn't really mention them too much today, but certainly they're very valuable to our efforts.
Well, thank you very much. Again, just a reminder to our participants, if you wish to claim this activity, please be sure to complete the sign-in sheet and the evaluation and to fax them back to OHA using the fax number that's listed on the top of the form. And again, please be sure that you provide the correct email or postal mailing address to which you wish to have your to receive your certificate of attendance. I would again like to thank Dr. Ho and Mary Ann Kramer.
Jim.
Yes. Yes.
We have one more question.
Okay.
Can you provide your nursing education tool for cultures and antimicrobials?
Certainly. We have, like I said, the initial training that we did, the pre and post knowledge assessment, and then that initial education. And then from that, we have now put together a 2-hour in-class antimicrobial stewardship lecture. We can certainly send that forward if you give us an address.
That would be wonderful. Again, thank you so much for your time today, Dr. Ho and Mary Ann. And as a reminder to all of us on the line, Wednesday, May 17th is our next call, 11:30 a.m. This concludes today's call. Have a great day.